Great. Okay. Thank you all for joining us this evening for another Restless event with our partners, My Menopause Centre. And this evening, we're looking at menopause and osteoporosis. Before I hand over to Helen, who'll chair this evening's event, I just wanted to remind you of a couple of points. Please post your questions and any thoughts you have in the chat function at the bottom of your screens. Feel free to post throughout the presentation, and we'll also make sure there's some time at the end for questions. So the event will run for an hour, and we are recording it, so it will be mailed to you all afterwards and to anyone who was registered for it. So now I'd like to hand over to our panel chair, Helen Normoyle, who is co-founder of My Menopause Centre.
Thank you, Aideen. Good evening, everyone. It's great to see you, and very glad we're not competing against the important match tomorrow evening. And despite Clare's orange cardigan, she is not a Dutch supporter. She is an England supporter. Good evening, everyone, and thank you so much for joining our live event, Healthy Bones, Healthy Life, Menopause and Osteoporosis. Now, it's clear that there's huge interest in this. We've had hundreds of people register for the event. And did you know that every 12 years, our skeletons undergo a complete transformation? Now, the chances are that you haven't thought much about your bones or bone health before, but osteoporosis, a condition where the bones become weaker, less dense, and more prone to breaking, becomes more common as we go through the menopause. It's often called the silent epidemic because it doesn't have symptoms unless you fracture a bone, and your bones may become less dense without you realizing it. Now, a couple of stats just to bring home this point and to underline the importance of today's conversation. At the age of 50, around 2% of women have osteoporosis, but this goes up to 25% by the time we're 70 years old. Around 1 in 3 women will suffer from a bone fracture as a result of osteoporosis in their lifetime, and women aged over 45 years spend more days in hospital because of osteoporosis than diabetes, heart attack, or breast cancer. Now, the really good news is that osteoporosis is both preventable and treatable. There's lots that we can do to maintain good bone health, and that's why I'm really delighted to be joined this evening by my co-founder, Dr. Clare Spencer, menopause guru and GP, and an expert in all things osteoporosis and bone health, Dr. Afroze Abbas. Dr. Clare, whom I'm sure many of you know already, is a registered menopause specialist and GP. She qualified from Cambridge University and holds membership of the Royal College of Obstetricians and Gynecologists and membership of the Royal College of General Practitioners. She's also a member of the British Menopause Society Medical Advisory Committee and is a menopause trainer. Dr. Afroze Abbas is a consultant endocrinologist and lead clinician for endocrinology at Leeds Teaching Hospitals NHS Trust. He's a member of the Society for Endocrinology, the Calcium and Bone Specialist Endocrine Network, and the Yorkshire Bone Network. He has been the lead investigator for osteoporosis-related clinical drug trials and is the lead for the Bone Health Service in Leeds. He also offers private consultations in Leeds and will provide details of those at the end of this session and when we mail out a link to the video. Now, a few house rules as ever. Questions are very much welcome. Please do pop them into the chat and we'll cover as many as we can. The webinar is being recorded and we'll share online over the next few days. Now, please remember that as ever, we're not permitted to provide any personal medical advice within this session, but we can, of course, comment on questions in a more general way. And please also remember that you should always talk to a medical professional before acting on any of the information provided. So, Clare and Afroze, thank you so much for joining us this evening. And let's launch in. Dr. Afroze, with a question for you. It would be wonderful if you could start by explaining what osteoporosis is and how it's diagnosed.
Thanks very much, Helen. Nice to see everybody on the call. Thanks for inviting me. It's a pleasure to be here. So osteoporosis, I thought your introduction touched on some important points there. So one of the things you mentioned was that the skeleton is renewed every 12 years, and that's true. So bone is a dynamic material essentially in the body. It's always being formed, it's always being broken down. No matter how old you are, that repair and regeneration, remodeling is always happening. But early in life, there's more formation than breakdown, and so the skeleton gets bigger and stronger, and that sort of steadies out. in sort of midlife. And as we get older, the balance between formation and breakdown of bone changes. So there's more breakdown than formation. And as a result, what happens is that you lose quantity of bone. So the amount of bone decreases, and also there's a decrease in the quality of the bone. And eventually that leads to weakness of the bone, and ultimately to fractures. So that's essentially what osteoporosis is. And there are various other factors which we'll probably come on to, which can influence how quickly bone is formed and how quickly it's broken down. But the problem with fractures and loss of bone is eventually that will lead to loss of mobility, loss of independence, pain, deformity. And some fractures can even be associated with increased risk of death. So essentially, that's what osteoporosis is. It does mean that there's more breakdown than formation, and unfortunately, that's part of aging. But there are things we can do to slow that down.
And then we mentioned in the opening some of the stats around the incidence or the proportion of people in the population who have osteoporosis, but we also said that it's a silent disease. So it would be really great if you could help us to understand, how do you actually know if you have osteoporosis? And do you think that the incidence is underreported?
Yeah, no, I think that's so important. So it is a silent condition, and every week I'll have somebody who will tell me, well, I didn't know I had osteoporosis. I would have not even thought that I had osteoporosis. So it totally goes under the radar, and often the only intervention really that leads to a diagnosis of osteoporosis is after somebody's had a fracture, by which time it's a little bit, it's not too late, but you wish you had diagnosed it way before, so you could have prevented that first fracture from happening. And the fractures that would make us think about osteoporosis are particularly what we call fragility fractures. So fractures that occur with minimal trauma, such as a fall from a standing height, etc. Those sort of fragility fractures really make you think, well, there's something going on in the bone. Could that be osteoporosis? And that's often the first way it is diagnosed. The best way to diagnose osteoporosis or low bone mass would be a DEXA scan, or what we call a bone density scan. And that would give you a guide as to the quantity of the bone, particularly in the key areas of the hip and the spine. But it's unusual to routinely get DEXA scans done unless there's a good reason for that. So most people would not know they've got osteoporosis unless for some reason they had a DEXA scan, or they had fractured something and then that had led to a DEXA scan being done. So that's essentially how it gets diagnosed. But when a bone density scan is done, when a DEXA scan is done, then that tells you how much bone there is. And then you compare that to a young, healthy female, usually. And depending on the score, that determines really whether you have osteoporosis or not.
And then just given what you said, Dr. Afroze, all other things being equal, so putting aside what the NHS will or won't do or what it can afford to do and people's personal budgets, but in principle, would you recommend that people take a DEXA scan in their 40s or 50s just to check in on their bone health?
So disregarding what the NHS can or can't provide, then there is largely no harm really in doing a DEXA scan. So a DEXA scan does carry some radiation, but it's about 1/10 of what you'd get from a chest X-ray. Okay, so there is some radiation exposure as a result of DEXA scan, but it's pretty minimal. And if we knew what bone density was like earlier on, then we would have a better idea of how it changed, and we would be able to intervene earlier also. I suspect, as you suggested there, that the reason people don't get DEXA scans routinely is it's a resource issue rather than any other issue really. But yeah, I think it would be helpful. But the other thing to think about is you can, even without a DEXA scan, have some idea of what your risk of fracture might be. So, you know, GPs and other healthcare professionals can do a fracture risk assessment, which can be done quite quickly, you know, within 5 or 10 minutes. And it gives you a guide as to whether you might be somebody who needs a DEXA scan for further assessment. So that fracture risk assessment can be done very quickly in a 5 or 10 minute consultation, and give a guide for people who would warrant a DEXA scan, particularly on the NHS.
Claire, it would be great to bring you in on that point, and thank you everyone. We're getting some fantastic questions coming in at the side, and keeping an eye on them, and we'll weave them in or take them at the end. But Claire, it would be really helpful if you could help us to understand why osteoporosis becomes more common during menopause, and you know how you think about it when you see your patients.
No, absolutely. So osteoporosis and osteopenia, which is loss of bone density that's not scored bad enough, if you like, to be osteoporosis, risk increases with the menopause, because in the menopause we lose estrogen, as we've spoken about many times before. And in the perimenopause, the start of the menopause transition, our estrogen level fluctuates, but on the whole, the average estrogen level will drop. And then, of course, we know after the menopause, after our last menstrual period, the estrogen level is low, and then it stays low. And that's really important because, as Dr. Afroze said, our bone is constantly building and getting lost. That it's always in balance, but estrogen keeps the balance more to bone building than bone loss. And also estrogen also has a role to play in how we absorb calcium, which is one of the building blocks of bone. So when we lose estrogen, it really starts in the perimenopause. As we start to lose estrogen, that balance changes more to bone loss than bone building. And that's why we know that bone density loss accelerates as you transition through the menopause. It's really interesting what Dr. Afroze was saying about the GP risk assessment. So it's called, I'm sure we'll pop it in the chat, but the FRAX score, FRAX. And so what that does is, I know we'll come on to talk about other risk factors for bone mineral density loss, but it looks at your age and your weight and your alcohol intake and whether there's a family history of osteoporosis, because it can run in families. But it's really important to know that the earlier the menopause, the greater the risk of bone loss is. So women who have a menopause under the age of 40 are at much greater risk of osteoporosis than women who've gone through the menopause at the average age around 50, 51. And of course, there isn't a cutoff at 40. There's a gradual increase or decrease, whichever way you look at it, with age. So one of the criteria to get a DEXA scan through the NHS is having a menopause under the age of 45, particularly not with HRT. And HRT is a good way of giving some estrogen back to help prevent osteoporosis and fractures.
Brilliant. Thank you, Claire. And we'll come back to other things that we can do and how we can prevent and treat osteoporosis in a moment. But Dr. Afroze, just on the point around other risk factors for developing osteoporosis, so Claire's called out menopause. We've had a great question in here from Julie. Thank you, Julie. She's wondering if it's genetic or if it's hereditary. So what are the other risk factors that you consider? In terms of risk factors for developing osteoporosis and fractures, the biggest risk factor is probably age on its own in terms of your fracture risk, but other sort of lifestyle things that can affect bones and your chance of getting osteoporosis, things like smoking, drinking alcohol more than 20 units a week is associated with an increased fracture risk. Being significantly underweight is also associated with increased fracture risk. Lack of weight-bearing exercise. As Dr. Clare said, early menopause for any reason without subsequent estrogen can increase your risk significantly. There's various medications that are commonly used, such as steroid medications, some anti-epilepsy medications, some stomach acid medications,
are associated with bone loss and osteoporosis. Then there are, in terms of other risk factors, common other health problems, which we know cause bone loss and osteoporosis, such as diabetes, rheumatoid arthritis, celiac disease, inflammatory bowel disease, things like that. In terms of whether it's hereditary or not, there is a strong hereditary sort of link. So one of the big risk factors for fracture that we worry about is if your parent, either mother or father, has had a hip fracture before, and we know that increases your risk of you having a fracture. So clearly there is a genetic link, and the genetics around it aren't simple. So it's not just one gene that causes osteoporosis. There may be several genes, several sort of genetic changes that can increase your risk of osteoporosis. So we rarely do genetic testing in osteoporosis, but we are very interested in the family history, because if there is a family history of osteoporosis, it might mean you're more prone to having accelerated bone loss and more prone to fractures. So that would be my take on it, really.
Brilliant, thank you. Now, we've had lots of questions in here around the scoring, and I'm presuming that the scoring that people are putting in here are linked to the FRAX and DEXA results. So, Dr. Afroze, if I could just put some of them to you in general. So, Anita, thank you. A DEXA result of -3.5 at the age of 55. Is that particularly bad, or where does that sit?
So there's two things about that. One, the DEXA result is just telling you what the bone density is, right? And we know that bone density is an important part of your risk of fracture, but it's not the only, like we've just been through other risk factors for fracture. So a T-score of -3.5 at that age is low, significantly low, I would say. But it sort of depends on what else is going on and what other risk factors there are as to whether that would need or what sort of treatment that would require. So yeah, T-score of -3.5, age 55 in a woman would be lower than I would expect, for sure.
So seek advice. And Claire, thank you so much for adding those links into the chat. So Claire's added some links into the chat where you can find out more about FRAX and FRAX scoring. And a question here again, can iron deficiency be a risk factor?
Not usually on its own. So it depends on what's causing the iron deficiency. So essentially, but iron deficiency on its own wouldn't necessarily be a risk factor for osteoporosis. But if there's something underlying that iron deficiency, like, I don't know, inflammatory bowel disease, things like that, that might be a risk factor in itself.
Great. And some other questions here, Dr. Afroze, around other medications, and apologies if you've mentioned these already, but a question around whether or not steroid medications are they associated with bone loss, including asthma medications as well? Can that have an impact? So
the steroid medication we worry about the most are the tablet steroids, things like prednisolone and dexamethasone that people take at high dose on a regular basis for a long period of time. They're the ones that are most associated with bone loss. Inhaled steroids, which are used in asthma, it's controversial really in terms of whether they whether they definitely do cause bone loss or not. And generally people need inhaled steroids to keep breathing, right, from an asthma perspective. So it's not something we massively modify from a bone health perspective. But the oral steroids are the ones to watch out for, particularly if they're given long-term at high dose.
Very good. And then that's really helpful. And then a few other questions around other risk factors. So questions around, do neurological conditions increase risk? Does stress in one's life increase risk?
Neurological conditions, depending on which ones they are, they can do. So we know some of the neurodegenerative conditions like Parkinson's disease, Alzheimer's disease, things like that are associated with an increased risk of osteoporosis and fracture. So certain neurological conditions definitely are, and there's many reasons for that. What was the second one?
It was stress in life.
Stress in life. It's a difficult one, I think. So one of the hormones which can go up as a result of stress is cortisol, which is a steroid hormone. And we know that high cortisol levels do deplete bone. Whether sort of stress in life is enough to raise your cortisol levels enough for long enough to cause bone loss, I don't know, is the honest answer. But we know there are medical conditions where your steroid levels are high, and that can cause bone loss.
Okay, thank you. Fascinating. And then a very interesting question here. Thank you, Narmda. Could a vegetarian diet mean that you're more prone to osteoporosis?
It shouldn't do, as long as you're getting the nutrients you need from your diet. So, particularly as long as you're getting enough calcium, your vitamin D levels are okay, magnesium, all that sort of stuff. If you're getting that, then your bone should stay healthy. So it shouldn't necessarily predispose you to it. Celiac disease celiac disease can predispose you to osteoporosis. But again, if you follow a gluten-free diet, that really helps with the bone health and the osteoporosis. So the dietary side of things is really important, but a vegetarian diet on its own wouldn't predispose you.
Okay, and actually, Dr. Clare, that's a great segue into you then, in terms of, we spoke about prevention and how we can manage this. So what steps can women take to maintain strong bones during and after the menopause?
Yes, yeah. So lots of parts to this, and I'd like to bring Afroze in as well for a bit. So, first of all, there are lifestyle factors. So we've touched on calcium. So a balanced diet is really important. You need calcium, but you also need other minerals to maintain good bone health. Most people don't need calcium supplements, and they're not very nice to take as long as they're getting enough in their diet. And there's a couple of really good calcium calculators that I signpost people to when we're talking about bones in a consultation. So there's the Royal Osteoporosis Society, I always get them the wrong way around, and the International Osteoporosis Foundation. If you Google calcium calculator, and it will take you through quite a detailed what are you eating, and will tell you if you're getting enough calcium in your diet, because we know calcium is rich in obviously dairy products, green leafy vegetables, fortified non-dairy milk, flour, bony fish. If you're having a milk substitute like soy milk or oat milk, there is no calcium in there unless it tells you that it's fortified with calcium. So people who are going non-dairy really have to look to make sure that they're getting enough calcium in their diet. Vitamin D is really important for bone building also. And again, vitamin D is found in oily fish, eggs, some types of offal like lamb's liver, and again, fortified foods. But vitamin D is converted to its active form through the action of sunlight on our skin. And from around September to April, May time, there isn't enough sunlight in the UK. So between April-ish and September, if we have 10 to 20 minutes a day, then that should be enough sunlight to convert enough vitamin D to its active form. But during those winter months, the NHS recommend that we take 400 international units or 10 micrograms a day of vitamin D, and that's everybody across the board. But there are some more at-risk groups, particularly people who are inside all year round or less mobile, people who have more pigment in their skin, take longer to convert that vitamin D to its active form. And Afroze, I'd really like to hear from you. So in the menopause transition, would you recommend that women take more than 400 international units a day? Because I've looked for evidence. I've heard people say different things, like menopausal women should take 1,000 international units or 2,000 even. But I think it is important for everybody to know that you can take too much vitamin D, and it can make the calcium go up to be almost too high in the blood. Yeah. So I'm always quite wary about advising with vitamin D dose. What do you think? What do you say?
So I completely agree with your points on both calcium and vitamin D. I think the issue, so we think that the optimal sort of level of vitamin D from a bone health perspective is between 50 to 100 nanomoles per liter when we measure it in the blood. The issue is that different people sort of run different levels of vitamin D. So some people will maintain vitamin D with very little sunshine, and some people need much more from their diet and stuff. Generally, 400 units a day for most people will help maintain their vitamin D in that level, but some people need more. And generally, in people with bone problems or who are at risk of bone problems, I tend to advise about 1,000 units a day, particularly in the winter months. But you're right, you can overdo vitamin D. And if you overdo vitamin D, then that can cause problems with high calcium, which can be really dangerous. So generally, most people are on between, in terms of maintenance dosing, somewhere between 400 to a maximum of 2,000 units daily. But for most people, 800 to 1,000, particularly in the winter, is probably okay. And particularly around the menopause transition, where we know women are going to get accelerated bone loss, then that would be a sensible time to optimize their vitamin D, especially over the winter months.
Yeah, no, that's really good to know. And with my GP hat on, we're encouraged not to measure vitamin D.
I know.
We have to jump through a lot of hoops to actually get to the blood test. So that always interests me, because it can be quite useful to just find out what your vitamin D is, can't it?
Oh, no, I think it is useful. And I think, again, it's a resource issue rather than anything else in terms of testing the vitamin D, because but generally we know that if you take somewhere like 800 to 1,000 units of vitamin D, almost certainly you won't be overdoing it. And for most people, that will be absolutely fine, and they will have optimal vitamin D levels on that dose.
Yeah.
So generally, if you're taking that sort of dose, you probably don't need to test it. The issue comes in people who we know have bone health problems, who have osteoporosis, who may be on treatments for osteoporosis. Then it's entirely appropriate to test their vitamin D.
Yeah. No, thank you. That's really helpful. And then obviously exercise. So doing exercise where stress is put on the bones and muscles. So weight bearing exercise, exercise where you maintain muscle strength, like jumping, running, dancing, are really good. But don't worry if you aren't up for jumping, running, or dancing, because pounding, walking can be helpful. And exercise, we know, can be good for building bones, but also can build muscle strength, improve strength, balance, posture, and that's really important for preventing falls, which obviously then increase the risk of fractures. So you've got the lifestyle stuff, and then with my menopause specialist hat on, HRT is a really good way of maintaining muscle bone density and preventing bone loss and preventing fractures. And at the moment, it's not recommended for women at the average age of the menopause in their 50s to take HRT just for bone loss prevention, just for osteoporosis treatment if they haven't got symptoms. But that is a really interesting discussion to have, because I know Afroze will maybe talk about other treatments for osteoporosis, and many women I'm seeing would much prefer to accept the very small risk of breast cancer as a result of taking HRT than take a bisphosphonate, for example. So HRT is a good way of preventing bone loss and preventing fractures. And it varies from person to person, but a bone sparing dose is around 2 milligrams of oral estradiol or a 50 microgram patch, 2 pumps of gel, or about 3 sprays of Lenzetto. It's quite tricky measuring that. I saw there was a question about how do you know if your HRT is absorbing enough to prevent bone loss? And the answer to that is it's really tricky. There isn't a cutoff threshold number that we know you have to reach, because even at lower doses, even at low estrogen levels, you do get some prevention of bone loss. So they are the ballpark doses, but you will probably get, we know that you'll get bone protection also at lower doses.
So I wonder if we might pause there a second, because we've had some fantastic questions come in around nutrition versus supplements, and also about HRT. And I know, Claire, you've got some questions for Dr. Afroze about some of the more specialist treatments. But if I could maybe put to both of you, and this is a question I think we hear a lot, for both of you then, what's your take on taking supplements versus getting the right level of supplements through your diet, through what you eat?
So in terms of the calcium, there's some evidence that supplemental calcium can reduce particularly vertebral fractures, but the evidence is really weak, and particularly it's in people who are deficient in calcium to begin with from a dietary perspective. So my view is that if you're getting enough, say, calcium through your diet, then taking supplemental calcium is not required. And as Dr. Clare said, the calcium calculators are a good way of working out how much calcium you're getting through your diet. And you know, if that's sort of about 1,000 to 1,200 milligrams per day, you don't need to take additional calcium. That's sufficient. Vitamin D is hard to get through diet, so you can get it from sort of oily fish and eggs and stuff, but it's largely sunshine, and so we're more prone to supplement vitamin D, particularly because we live in the north of England and there isn't enough sunshine, as today has demonstrated. So yeah, so we do need, I think, to take vitamin D, particularly over the winter months, to maintain bone health. And I think that's important, but generally don't supplement if you've got enough coming in through diet, essentially.
Yeah, I think that's very clear. So we had several questions on that. So thank you for being so clear on that. And then a really interesting question. Thank you, Faye. Can our nails be indicative of our bone health or of our grip strength?
Can the nails be indicative of bone health? I haven't seen any direct correlations of nail health versus bone density, so I don't think so. Grip strength, there was a question on grip strength as well. Did you say? Yeah, so grip strength is a good sort of biomarker of muscle strength and things like that. So grip strength does give us an idea in terms of musculoskeletal health, particularly. And in sort of clinical trials I've done, it's been used as a surrogate marker for musculoskeletal health. So it's useful, but we don't measure it routinely in clinical practice.
I went to a lecture years ago by an old gynecologist who had an interest in bones, and he said a really good measure is looking at your wedding photograph and comparing your height next to your husband's stroke partner compared with your height now.
Yeah, I mean, we talked about it being a silent epidemic, but one of the things apart from fractures is height loss. If you're losing height loss, you know, if you're losing height significantly, so more than 2 or 3 centimeters a year, then it can be indicative of osteoporosis and potentially spinal fractures as well.
Brilliant, thank you. And then before we move on to some questions about HRT, and Claire, you've seen some of them in the chat. Again, thank you, Bex, for your question. At what age are we laying the groundwork for bone health stroke bone ill health? And the reason this question is being asked is because Bex's daughter she's 8, she's been a vegan and gluten-free for her whole life. She's several intolerances and cyclical vomiting. So diet is a big issue for her. So any advice for young people in particular?
So bone density, in terms of just, you know, like I said, it's not the only thing that leads to fractures and osteoporosis, but bone density peaks in your sort of mid to late 20s, right? And then it stays fairly stable between that and, for women, sort of the menopausal age. And then it drops fairly rapidly for a few years. So you actually reach peak bone density in your mid to late 20s, and that sort of sets the pattern in a way, because if you don't reach a good peak bone density at that age, then you're more likely to end up with osteoporosis later on in life. So, but the thing is, we don't measure peak bone density because hardly anybody will get a DEXA scan in their mid-20s, right? So we don't have that evidence, and we don't know what somebody's peak bone density was. But we do know, when we do measure it, the people who have osteoporosis or low bone density at 20 or 30, and if that can't be reversed for whatever reason, they're more likely to end up with severe osteoporosis later in life.
Okay, thank you. And a segue into, thank you, Teresa, a really great question for both of you again. Is it possible to control osteoporosis through exercise and diet alone rather than through medication?
It depends what you mean by control, I guess. Is it possible to reverse it in terms of postmenopausal osteoporosis? I don't think it's possible to reverse it, but what you can definitely do through diet and exercise is change the speed at which you lose bone, right? And help you maintain bone, definitely. So if you've already got osteoporosis, it's unlikely that that will be reversed just through diet and exercise, unless there was some particular factor that led to the osteoporosis in the first place. But you can definitely help maintain bone health for, better and longer by looking after yourself. And we know that people who don't exercise and who have dietary issues and who smoke and drink a lot of alcohol and stuff, they will lose bone much faster than people who do.
Yeah, so much comes back to lifestyle, doesn't it? Clare, I know you had some other questions for Afroze. There are more specialist treatments available.
Yeah, no, I thought it would be interesting, Afroze, to talk about the different treatments for osteoporosis. And I often get asked whether, say, bisphosphonates are better than HRT and vice versa. So I think it would be really interesting. I've sort of touched on HRT, but interested to hear from you about other treatment options.
Yeah, I mean, in terms of, so generally, the osteoporosis treatments are divided into two camps. One are a set of drugs that stop bone breakdown or stop the cells that break down bone. And then there's another group of medications that build new bone or bone forming agents. And the drugs that we use most commonly are the family of drugs called bisphosphonates, of which people will have heard of things like alendronic acid or risedronate or ibandronate or zoledronic acid. So these are all bisphosphonates, and they tend to be the first line sort of pharmacological agents used in osteoporosis. Is HRT better or worse than bisphosphonates? I think that they're pretty much similar in terms of the bone efficacy, and fracture efficacy. We know that HRT works very, very well at preventing fractures, and is particularly useful in women who are going through just after the menopause, in that sort of 50 to 60 age group. I think it works really well there, and definitely has some advantages over bisphosphonates in that age group. There are not many head-to-head studies of HRT with bisphosphonates, but what's interesting is that HRT plus bisphosphonate in your high-risk patient, there seems to be an additive effect. So there are some studies there. So in people who are high risk, you can use HRT and bisphosphonates together because they work differently. Their mechanism of action is different, and there seems to be an additive effect on particularly on bone density. So I think there's a place for both bisphosphonates and HRT, and its sort of individual circumstances which determine what would be the right treatment. So apart from bisphosphonates, which are sort of anti-bone breakdown, there's another injection that we use every 6 months called denosumab, which has very, very good data. And then we've got some new bone forming agents as well, such as there's a drug called Evenity, and there's a sort of daily injection we use called teriparatide, and they have excellent anti-fracture and bone density data in terms of forming new bone. So we have a whole sort of arsenal of things we can use, but they have to be individualized really to a person's circumstance. And some of that is around, where they are in life. Some of it is around what their risk factors are. Some of it is around how high risk they are of fractures.
Thank you. No, that's really helpful. And I really agree with your point. It has to be an individual decision, doesn't it? So
yeah,
talking about the risks and benefits of different treatment options. And I know there's a lot of worry about taking bisphosphonates and rare side effects, and do you need to stop them after a period of time? Again, we hear that anxiety quite a lot.
Yeah, so with the oral bisphosphonates, by far and away, the commonest side effects are the gastrointestinal side effects like reflux, indigestion, ulcers, things like that. But the rare side effects that people worry about a lot are the two main ones are osteonecrosis of the jaw, where the jawbone doesn't heal properly, particularly if it's injured, during dental extractions and things. And the other one that people worry about a lot is something called atypical thigh fractures, which are unusual fractures that occur at the top of the legs, which we think can be related to long-term bisphosphonate use. Both those rare complications, osteonecrosis of jaw and atypical thigh fractures, are really rare. So, I have looked after thousands of people with osteoporosis, and I'll have seen a handful of cases of both those things in the last 15 years. So it is really rare. And what you have to do is balance that risk of those rare complications versus the risk of breaking a hip or the risk of breaking a spine. And generally speaking, for most people, the benefit of bisphosphonates outweighs those really rare risks of bisphosphonates if we decide to treat with bisphosphonates. But it is true that the longer you're on bisphosphonates, the more likely you are to run into those rare complications. And there does seem to be that association. So the guidance is at the moment that if you are low risk of having fracture, then if you're on an oral bisphosphonate tablet, then we would reassess the need for that tablet at 5 years. And often we would give a break from treatment. But then if you're high risk of fracture, then that's a different judgment call. Really. So again, it needs to be individualized. But yeah, in quite a lot of people, if we can stop treatment for a while, we will.
Yes, yeah. And there's a question here. I'm just having, so sort of illustrating one of the points or giving an example of treatment. So Anita, thank you for your comment. So Anita was the person with the DEXA scan score of -3.5. She'd had 3 years of zoledronic acid intravenously, advised by rheumatologist, wondering if was this not needed, as many side effects on HRT2. And it's really difficult without knowing the medical history, isn't it? But does that sound fairly typical?
It's difficult without knowing the individual factors to it. So, if on HRT, then that should be helpful and protective from a fracture perspective. If they felt the need to also give an intravenous bisphosphonate, then potentially that suggests that they felt it was a high risk situation in terms of fractures because they needed to treat with both things. So it's difficult without knowing the individual circumstances. But like I said, there is an additive effect, we think, of using bisphosphonates with HRT. So for the high risk patients, it would be a reasonable strategy if you were high risk.
Yes. Yeah. And then just going back to what we were talking about in terms of diet and other risk factors. So Beck's asking for a little more information on alcohol and bone health and what the link is there. A question on the forefront of many patients' minds that I speak to, I have to say.
So there's pretty good evidence that if you drink consistently more than 20 units of alcohol a week, then that is detrimental to bone health. And 20 units, I don't drink alcohol, but 20 units I think is not that much probably for some people. So, but it is associated with bone loss, and that's probably as a result of decreased bone formation. So the alcohol poisons the cells that build a bone, and so you get decreased bone formation. So, I mean, that's a really clear and strong risk factor for bone loss.
Yeah, no, absolutely. And I think what comes out again and again, and again, looking at some of the questions, is you can have osteoporosis, but if you but the treatment recommended and how long treatment, etc., is really dependent on other lifestyle and medical risk factors. I know I've asked you this before about patients that I've treated. Yeah,
totally. So, you know, I have patients who on their scan they have osteoporosis, but I won't be treating them with any drugs because their overall risk of fracture is not high. And I have patients who technically on their scan have osteopenia, so their bone density looks a bit better than patients with osteoporosis, but I will be treating because they have other risk factors which would mean that they're much more likely to fracture. So the bone density side of things is only one part of the whole package, and it does need to be individualized.
Yeah, so hence great that we're talking so much about diet and lifestyle and other risk factors. Yeah. Okay, thank you.
No, it's fascinating, and clearly, Dr. Afroze, we need more Dr. Afrozes across the country to raise awareness of this. It's so important because knowledge really is empowering, and hopefully everybody who's on this evening's webinar and who will view it, all the hundreds of people who registered who view it, will take away the fact that there's lots that you can do to prevent to prevent this or to manage the condition, and lifestyle being key. But just a couple of general questions. So for people who really suffer from fatigue and who struggle to exercise, what are your thoughts or suggestions? Because we stress so much the importance of exercise and how it can help. If that's you, and that's tough, isn't it? You know, what advice, Dr. Clare, Dr. Afroze, would you give to somebody in those circumstances?
I think it's really difficult, isn't it? But even any sort of weight bearing is beneficial for bone. So whatever you can do within your capability will help. So any sort of weight bearing through the bone is helpful. And we know that, you know, people who are, you know, can't get up and are bed bound, they're much more likely to get bone loss and osteoporosis than even the people who manage to walk a little bit every day. So just it's whatever you can do within your capability, but particularly sort of low impact exercises like walking, things like that are helpful. Any weight going through the bones is helpful, essentially. So do what you can is the message.
That's what I say. Start tiny, particularly women in the menopause struggling with feeling overwhelmed, fatigue, etc., and just can't get that motivation just to do it. You know, I think it's really natural, isn't it, that many women I speak to want to go back to what they were doing 20 years ago immediately because they're so frustrated, but just really start small. And that's, of course, and I know there was a question about respiratory disease and heart disease and whether that can increase the risk. And if it's linked to immobility, then obviously that is an important factor.
Yeah,
brilliant. And Clare, a question for you on HRT. I'm so pleased, Rita, that you've asked it. Thank you. Can someone who's on medication for osteoporosis due to POI take HRT at the age of 64?
Yeah, so you can start HRT at any age, basically. You do at the age of 64, if you didn't have any symptoms of the menopause, it would need to be a careful discussion because with age, your risk of breast cancer goes up, the risk of blood clots, stroke increases with age. And if you start HRT age 64, you don't get the benefit in reducing the risk of heart disease that you would have had if you started it within 10 years of the menopause or under the age of 60. But you probably will get some benefit to your bone. You just have to be careful about the type of HRT that you take because of the blood clot risk. And a careful discussion would need to be had. At the age of 64, I would start a really low dose of estrogen. And, you know, you would get some benefit from that, but you would have to increase the dose to get more benefit. And in all honesty, we just haven't got the data to tell us how safe or not safe starting HRT in your mid to late 60s is. Starting a low dose of transdermal estrogen through the skin with micronized body identical progesterone is probably minimal risk and probably doesn't increase your risk of heart disease either, which I know has been a concern in later years. But yeah, an individualized discussion, the answer is probably not no. but you'd need a good chat with somebody like a menopause specialist like myself to just talk about the risks and benefits, what we know, what we don't know. Afroze, would you have any comments on that?
No, I would agree with you. Generally speaking, at that sort of age, I wouldn't start HRT primarily for bone health benefits. So there would have to be other reasons to be thinking about HRT and not just bone health.
Yeah.
Yeah.
Thank you. So I can't believe it, but we're into our last few minutes. A couple of, I noticed a question that we missed earlier on. Is there any connection between osteoporosis and osteoarthritis?
No, in a word. I don't.
Short and sweet.
No, they're different. They're different conditions, which work in, you know, the mechanism is different. So we don't think there's a direct connection between the two.
People often get confused between the two because I always ask about family history of osteoporosis, and people do, yeah, osteoarthritis is wear and tear arthritis. Osteoporosis, obviously, we're talking about. Yeah,
and arthritis is the joints. It's the joints that are the issue, whereas osteoporosis, it's the bones themselves. So they're different.
Yeah.
Yeah, and I've put a couple of links into the chat from the symptom checker on our website. So where Clare has written a piece on osteoporosis, but also on joint aches and pains. And she talks about menopause related joint aches and pains and arthritis as well. So for people who would like a little bit more information on that. So last couple of questions before we finish. Another question again, Clare, can you take an extra estrogen pump gel if you're on a combined patch already?
I prefer not to, because we don't know that the combined patch has enough progestogen in it to keep the womb lining thin when you start piling estrogen on top of it. It might do, but it might not, and it would depend on what your risk factors are for womb lining thickening. Remembering that HRT is two hormones, estrogen and progestogen. Estrogen helps symptoms, but can thicken the womb lining and increase risk of cancer of the womb lining in the long term. So you need the progestogen alongside to keep the womb lining thin. And we know that balance does keep the womb lining thin in a combined patch where you get standard dose of estrogen with a dose of progestogen. But if you start adding estrogen on top, we just don't know. So again, it would need a discussion. There are other options.
Brilliant, thank you. I think we'll need to leave it at that. We're almost out of time, but Dr. Clare and Dr. Afroze, thank you so much. That's been a really great conversation. And thank you everyone for all of your questions. They were fantastic, really insightful. I can see why there was so much interest in this, but great practical advice on how we can look after our bone health through all life stages. So you've both had very busy days in the clinic. Thank you so much for taking the time this evening for this webinar. And you can find out more about my Menopause Centre on our website. We put in the links, and when we send out the video, we'll send through details of how you can get in touch with Dr. Afroze if you'd like to chat to him as well, or book an appointment to see him to talk about any concerns or questions that you might have about osteoporosis. So with that, I will now hand back to Aideen.
Thanks, Helen, and thanks everyone. That was such an amazing event. Some great advice and help for our members. So thank you very much. If you'd like any other further information, as Helen said, you can find that on hello@mymenopausecentre.com. And as I mentioned before the event, you will get a link to the recording directly afterwards. So thanks once again to everyone, and good night, and thanks for enjoying us. Enjoy the rest of the evening.
Night, everyone.
Bye-bye. Good night.
Bye-bye. Bye.
Bye.